But in the United States, we've also recognized that people who aren't terminally ill have a right to refuse treatment. Early on, they didn't, but now they do. I mean, somebody has, say, a degenerative neurological disease that's going to take them 10 years to die and their quality of life is terrible. They have a right to refuse treatment. In the Netherlands, those kinds of people, if they have what's judged unbearable suffering, they can be euthanized. They actually have, the courts have rejected the idea that people can be euthanized for what's called weariness of life. So there have been cases where somebody who's 85 years old and their family, their spouse is dead, maybe their children are dead, all their friends are dead, they feel useless, but they don't have a specific medical disease. The courts have ruled that they can't do it. Now, there are people in the Netherlands who don't agree with that, but they have drawn some lines. And also, most Dutch physicians support euthanasia, but most Dutch physicians don't like to do it. They do it, but they don't like to do it. And I think what that shows, I don't think it shows it's wrong, and they don't say it's wrong. It just says that, you know, it's harder to turn off a ventilator than it is to write a DNR order. And killing somebody, you can't hide it from yourself or anybody else. And so I think, I'm actually relieved to hear that. And in the Netherlands, the incidence of euthanasia has not gone up. One of the worries was, oh my God, they're going to start doing this to everybody, and that has not happened. So maybe, and Netherlands is a very different society than our society, that maybe in the right society that can be accepted. One other quick comment. The Netherlands was criticized, and fairly so, that they actually adopted euthanasia laws before they had a good palliative care and hospice system. And I think that just about everybody who I would consider responsible on either side of the issue would say this should never be considered unless all palliative and hospice care had been given. They have now developed a national system of palliative care and hospice program, and how good it is, they think it's pretty good. I haven't, been able to evaluate it, but they've taken that seriously.
Albeit in a reverse sequence than one might have preferred.
Right. Well, my comment about that is a little cynical, is that the impetus to the hospice movement in many places and the backing of the hospice movement by the AMA was because of the movement for physician-assisted suicide, in large part. And my cynical comment about that is that the doctors in hospitals, they thought that people killing themselves was so bad that they'd even be willing to treat their pain to stop it from happening.
We are listening to a special program featuring Dr. Dolores Christie, Executive Director of the Catholic Theological Society of America, David Simpson, CEO of Hospice of the Western Reserve, and Stuart Youngner, MD, and Chair of the Department of Bioethics at the School of Medicine at Case Western Reserve University. Our moderator is Eric Kodish, MD, and Chair of the Department of Bioethics at the Lerner College of Medicine at the Cleveland Clinic. Now we're going to return to the panel before we have some questions and answers here, but first I want to make a few announcements. Now, we want to return to our speakers for the traditional question and answer format, and again, we want to tell you that guests are certainly welcome to ask questions, and holding the microphones today are our special program committee co-chairs, Ellie Sullivan and Mike Kallstrom. And we do ask that you keep your questions very short and to the point. Now, the first question. Who wants to have the first question?
Thanks. I'd like to direct the question to Mr. Simpson. How would hospice care different if you were the director in Oregon as opposed to Cleveland?
Great question. I believe, well, our hospice, anyway, I would say undoubtedly revisit the philosophy statement that I read is what we have adopted. We would probably revisit that in the context of such a situation, and I would be fairly certain come out with a similar position, maybe modified around that. I don't think we would deviate from that value that we've taken in connection with that. We would probably refer people to an appropriate resource where they might be able to obtain the wishes, to have their wishes fulfilled in the way that would meet their perspective. We have a very, very, I would say, docile, wholesome, and supportive connection with people. And as I said in the philosophy statement, we would not abandon people. And I will tell you, we have had, over the years, some suicides. And they're very devastating. They've been very devastating. I would say the situations that I've heard described from Oregon are less so. But I think we would probably maintain our philosophy. We would probably look at it, though, again.
So, David, can I just jump in? When you've had suicides in the context of hospice, have you gone back and looked at them and then said, geez, we could have done this or we could have done that?
Sure, we have. It's not only devastating in relation to the family, but to the staff that have been working with the family. And the ones that I recall were violent. They were with guns. And that occurred...
in homes?
Yes, in private homes, yes. So, and we know a lot of our, we have 1,500 patients. There's probably a handful that will talk about suicide, and we work with them. So it's not something that it doesn't happen. It's part of reality.
Thank you. In the Compassion and Care program, the issue came up of a woman whose family had clearly stated to the doctors that they did not want treatment. The paperwork had all been done. The patient had filled out everything in advance, and the doctors absolutely refused to give up treatment. They continued invasive procedures, and the man had to go on and suffer. What are the reasons that doctors refuse to follow those orders when they're clearly written and the family knows about them?
Dee?
Well, I think one of the reasons is the doctor's moral goal is always life and health. And I think, and I can speak for my husband, the doctor here, that many of his colleagues have a great deal of difficulty facing the death of a patient when there are technological things that can still be done to keep the body maintained. But I think that's something where hospice has been helpful. It's a culture that is hard to break down. In this city, we have that culture in some of our hospitals with some of our physicians. I think it's the doctor's moral goal. The technology is there. Sometimes I think it's fear of if the family isn't in agreement and if the patient cannot speak for themselves, and particularly when the patient does not have some kind of advance directive which protects the doctor from family squabbles that may result in suit, that it's very difficult sometimes to stop. And I think what Stuart said earlier about the psychological trajectory, when you're working toward cure, when you're working toward keeping organs going, the difficulty of stepping back and saying, no more. Both from the technological point of view, that it's just going to prolong the dying, but also certainly, and perhaps more important, from the patient's wishes point of view, that the doctor needs to appreciate that it's not his or her life, it's the life of the patient and the family.